So, good evening, guys, and just lend me a minute. I'll just share the link because the scheduled streams usually in YouTube are. So, let me share this link of direct live so at least people can join in and then we can begin the session, right? So, as all of you are quite aware of the fact that So for all the new joiners who are there, I am Dr. Omkar Sangita Dilip Rao Sonone and I welcome you all back to the session of Sparks, and today's discussion would be the part 2 of our cardiology and respiratory medicine revision. Along with that, we'll be discussing some important subjects, integrated one, and along with that we'll also discuss some important points about the ECG. So all of you who are interested in ECG, please be patient throughout the session and please be cooperative and answer the questions in the chat box. I would be more than happy if you guys are able to answer these questions. Okay, please don't be apprehensive and just answer these questions. Okay, so now moving with our first question for today, guys. I hope everything is clear. You can see my screen clearly. Okay, and please share the link, guys, in whichever group you are added to, because let people join in. So now starting with question number 18 where we left earlier. So now the question number 18 says that a 28-year-old female presents with history of 9 kg of weight loss in the last 3 months despite an increased appetite. She also complains of diarrhea, anxiety and amenorrhea. Examination reveals fine tremors, brisk reflexes and systolic murmur which is heard throughout the precordium. Her urine pregnancy test, that is your UPT, that came out to be negative. What is the most likely diagnosis or finding on examining the pulse? Okay, so now they want to ask you that what is the most likely finding on examining the pulse. Okay, so first of all, to know that what would be the character or the pattern of the pulse, you need to come to a provisional diagnosis again, right? एक preliminary diagnosis होना चाहिए दिमाग में, then you can come to a conclusion that what type of pulse it would be, right? So can anybody tell me what is the disease that you are thinking of in this condition? What is the provisional diagnosis that you can think of? A young female presenting with the history of weight loss but having an increased appetite. Okay, having an increased appetite. She is also complaining of diarrhea, that is increased gastrointestinal motility. She is complaining of anxiety and some endocrinal dysfunction, right? Amenorrhea. Okay, with fine tremors and brisk reflexes. Brisk are your exaggerated reflexes दिखता है, and there is systolic murmur which is heard throughout. UPT came out to be negative. So what is the most likely diagnosis? This PDF can be found in the AFMG Telegram group or Target AFMG group on WhatsApp. So either of them you can find this PDF. I'll send you this edited PDF by tonight when I complete all these questions, right? So please remember, guys, the diagnosis in this condition, the probable diagnosis would be thyrotoxicosis. ठीक है, क्या लग रहा है यहाँ इस condition में there is thyrotoxicosis. So can anybody tell me now what is the type of pulse usually seen in cases of thyrotoxicosis? Now the question has been simplified. Can anybody tell me this? So just tell me what is the type of pulse seen usually in cases of thyrotoxicosis. So we'll move further. So please remember the diagnosis in this case, guys, is your thyrotoxicosis. Here there is a female with weight loss despite an increase in the appetite. There is amenorrhea, there are tremors and brisk reflexes. All of them point towards the diagnosis of thyrotoxicosis, right? Thyrotoxicosis is an emergency condition whenever the patient is suffering from hyperthyroidism, right? Can anybody tell me in the chat box what is the most common cause of hyperthyroidism? Just tell me in the chat box. Now, thyrotoxicosis can be associated most commonly with which cardiac pathology? So please remember, thyrotoxicosis is commonly associated with atrial fibrillation. thyrotoxicosis is commonly associated with atrial fibrillation, and therefore we all know in cases of atrial fibrillation we have discussed there would be an irregular pulse. Okay, irregular rhythm bhi hoti hai ECG pe, and the pulse would also be irregular. Okay, because the cardiac output would be varying. Okay, so there would be a irregular pulse. Important one in cases of atrial fibrillation, which is the most common cardiac association of your thyrotoxicosis. Yes, very good, Nirali. The answer would be Graves' disease, which is the most common cause of thyrotoxicosis or hyperthyroidism. Okay, please remember. Then, now ruling out, how can we rule out option A? Option A was your pulsus alternans. What do we mean by pulsus alternans? There would be a alternating pulse, okay? Alternating high amplitude and a low amplitude pulse. Something like this, okay? Something like this would be seen. Alternating high and low amplitude pulses are seen, which is suggestive of left ventricular failure. And left ventricular failure would be seen in conditions like cardiomyopathy ho gaya, congestive heart failure ho gaya. In all these conditions, we'll find usually pulsus alternans. Whereas option C, that is your pulsus paradoxus. We have already discussed about pulsus paradoxus in the last session. So pulsus paradoxus or paradoxical pulse means fall in systolic blood pressure of more than 10 millimeters of mercury during inspiration, right? And pulsus paradoxus is commonly a finding seen in cases of cardiac tamponade. Along with cardiac tamponade, it is also seen in cases of right ventricular failure. Also, that person can land up into cor pulmonale, also in cases of superior vena cava, that is SVC obstruction, and also in cases of acute asthma. In all these conditions, we can see paradoxical pulse. Option D was your collapsing or Corrigan's pulse, also known as water hammer pulse. So तीन नाम क्या इसके? Collapsing pulse, Corrigan's pulse or water hammer pulse, which is a feature of aortic regurgitation, right? In this, what happens, there is a very high amplitude pulse which suddenly falls, okay? Very high amplitude pulse which collapses suddenly. That is known as a collapsing water hammer or a Corrigan's pulse. So this is your ABCD of pulse. The most important pulse characters that you need to remember: A, B, C, D. Okay, A goes for pulsus alternans, which is usually seen in cases of LVF, left ventricular failure. Then also A goes for anacrotic pulse, and anacrotic pulse we have discussed, it is seen in cases of aortic stenosis. Next is your B. B goes for your pulsus bisferiens, okay, when there would be two peaks in the systole. Okay, and this pulsus bisferiens is usually seen in cases of HOCM or hypertrophic obstructive cardiomyopathy. Then C goes for your Corrigan's or collapsing pulse, also known as water hammer pulse, seen in cases of aortic regurgitation. And lastly, D goes for your dicrotic pulse, which is seen in cases of dilated cardiomyopathy. I hope this is clear to you. So the answer to the last question was option B. Irregular pulse is seen in the above condition because the above condition is thyrotoxicosis, which is most commonly associated with atrial fibrillation, right? Important. Moving further to our next question, guys. So this was a bit tricky question, the last one, because there was not a direct diagnosis which was given. This kind of questions are usually asked in AIIMS or NEET PG examinations. In our examinations, there would be somewhat a direct question which can be asked, but there would be clinical cases. Okay, don't expect one-liners. Like one-liners would also come in the form of clinical cases nowadays, right? So now moving further to question number 19, where the question states, a 17-year-old female with a history of pleuritic chest pain, joint pains, came to her doctor because she noticed an erythematous rash on her face. Okay, erythematous rash on her face. Further workup showed a positive anti-nuclear antibody, that is positive ANA titer was seen. Along with that, there was anemia, there is leukopenia, and there is a mild thrombocytopenia, right? The liver and renal profiles are within normal range. Echocardiography revealed vegetations. So echo is showing vegetations which are present in the undersurface of the valves. Which type of endocarditis is seen in this condition? So now can anybody tell me this, that which is the type of condition, which is this type of condition where there is a young adolescent female who has a history of pleuritic chest pain, okay, a sharp चुभने वाला पेन होता है ना, okay, so a sharp pointing chest pain would be there. There would be joint pain, that is arthralgia, can also be associated with arthritis. Then there is a erythematous rash on the face, a red colored rash on the face. Workup is showing positive anti-nuclear antibody titer. There is pancytopenia, that is anemia, leukopenia, and thrombocytopenia. Liver and renal profiles are somewhat normal. But what can be a probable provisional diagnosis? Can anybody tell me? Then we can go to the type of endocarditis which is seen in this condition. First come to a diagnosis, guys. A young adolescent female, arthralgia, pleuritis, erythematous rash on the face. erythematous rash कौन सा होता है फेस पे? इस पैटर्न में कुछ positive antinuclear antibody titer. This is an autoimmune condition, most commonly from rheumatology. याद कर लो. Pancytopenia. Liver and renal profiles are within normal range, but echo shows some vegetations on the undersurface of the valves, which is a probable diagnosis. All of you are pointing towards infective endocarditis, but please give me a provisional diagnosis first. Then you will get to know that what is the correct answer. So yes, very good, Nirali. The answer over here is option SLE, that is systemic lupus erythematosus. So now this is the provisional or preliminary diagnosis. Yes, that erythematous rash that I am talking about on the face, that is a butterfly rash or a malar rash, which usually spares the nasolabial folds. ये नहीं involve होता. And whenever the nasolabial folds are involved, that is seen in lupus perniosarcoidosis. याद रखना. Yes, so the diagnosis is SLE, and very good Komal, very good Nidhi. The answer over here would be option C, Lippmann-Sachs endocarditis. याद रखना, the most common type of endocarditis associated with SLE would be Lippmann-Sachs endocarditis. याद रखना, whenever the vegetations would be seen on the under surface of the valves. याद रख लेना. Infective endocarditis is common, but with SLE, the most common one associated is Lippmann-Sachs endocarditis. ये important है, याद रख लेना, please. Okay. So now let's discuss about the other options too. Option A says non-bacterial thrombotic endocarditis, and this non-bacterial thrombotic endocarditis usually will have sterile vegetation. Sterile मतलब कोई भी bacteria, कोई bacterial component present नहीं होगा. So it will have sterile vegetations which are smaller in size, they are warty and are present along the lateral surface. For example, these are your valves. So these vegetations would be present along the lateral surface of the valves. Okay, and they can be seen usually in cases of malignancies. Okay, and these non-bacterial thrombotic endocarditis, which is usually associated with malignancies, is known as merantic endocarditis. क्या बोलेंगे इसको? Merantic endocarditis. Okay, so please remember, the common type of endocarditis associated with malignancies is known as merantic endocarditis, which is a non-bacterial thrombotic endocarditis. Okay, wherever the valves are present along the wherever the vegetations are present along the lateral surface of the valves. Option B says infective endocarditis, and as we are quite aware of the fact that in cases of infective endocarditis, these vegetations are usually larger in size, they are bulky. Okay, and that's the reason why they are friable. Friable means easily breakable. Okay, and they are irregular in shape, and they are present in the valve cusp. Okay, so valve cusp जो होते हैं ना उसमें present होंगे. Okay, so please remember, in infective endocarditis they are present all over the valve, on the valve cusp. These vegetations are larger, bulkier, irregular, and they are fragile, friable. So what do we mean by friable? That means they are easily breakable, therefore they can break and they can lead to embolism. ठीक है, वो break होंगे और कोई भी vessel में जाके lodge कर जाएंगे. Okay, so that can lead to embolism, and this similar kind of question came in the August 2020 examination when the diagnosis was infective endocarditis, and they were asking that along with these other findings that were seen, along with that there was a very characteristic finding seen, that was splenomegaly. Okay, splenomegaly was seen, and that splenomegaly was due to the embolism which was dislodged from the valvular surface, and that got lodged in the splenic circulation, either in the portal vein or the splenic vein, leading to congestion of the spleen, finally landing the patient into splenomegaly. So याद रख लेना. So in in infective endocarditis, usually the vegetations are very fragile. Next, option D is your rheumatic heart disease, in which you can see small, warty, firm and sterile vegetations. Okay, small, warty, firm and sterile vegetations. So as these are firm, they cannot be easily broken down. Okay, and they are usually seen along the lines of closure. You can also see, you can also call it as along the lines of closure or commissural surface. क्या बोलोगे इसको? और commissural surface. So over here they would be seen in cases of RHD. Okay, last one is your Lippmann-Sachs endocarditis, usually seen in cases of SLE, which was our answer, in which the vegetations are usually sterile. Okay, they are firm and they are seen on the under surface of the valves. Okay, यहाँ पे दिखेंगे. Please remember this. Okay, so I hope this is clear to you. Now moving on to the next question. Endocarditis and rheumatic heart disease are very common and important questions. Either one of them would be asked in the examinations always. Now moving on to question number 20, which states a 48-year-old man is admitted to the hospital due to chest pain which is lasting for 3 hours. He has a history of smoking a pack of cigarettes daily, okay, a pack of cigarettes daily for the last 7 years. So he's a chronic smoker. No drinking habit, but his family history has cardiac events. So he has a positive history in the cardiac pathologies. On cardiac examination, heart rate is 51 beats per minute. As we all know, 60 to 100 is normal heart rate, so less than 60 would be bradycardia. So the person is suffering from bradycardia. ECG shows sinus bradycardia and ST elevation in lead 2. So these are the standard lead which we usually check in cases of ECG. What is the diagnosis? Non-bacterial thrombotic endocarditis, please remember it is seen on the lateral surface of the valves. For example, these are your valves on the lateral surface of the valves. Along the lines of closure, you will see vegetations in rheumatic heart disease. Yaad rakh lena. Please remember, okay? So, can anybody tell the answer? What is the likely diagnosis in this condition? So, first of all, let's see the ECG. उन्होंने क्या बोला? ECG पे क्या दिख रहा है? There is sinus bradycardia. Okay, ECG पे क्या क्या दिखते हैं usually? You will see a P wave. Then you will see a normal QRS complex and then a T wave, right? And then you will see a rhythm. So यहाँ पे हमें QRS complex दिख रहा है, T wave दिख रही है, okay? Then we can see a normal rhythm, ठीक है? There is regular RR intervals. So the gap between each RR interval is equal. So that means there is a regular RR interval. Only there is increased gap between the RR intervals. Means that is there is bradycardia. So याद रखना अगर ज़्यादा boxes होंगे दो RR के बीच में, that is the patient is suffering from bradycardia. अगर कम होंगे the patient is suffering from tachycardia. So yes, very good. Please remember the diagnosis in this condition is option D, ischemic myocardial infarction and inferior wall. So कैसे पता लगा है? Let's see. First of all, उन्होंने क्या बोला है? Lead 2 देखने के लिए बोला हमें. Lead 2 में क्या दिख रहा है हमें? T wave inversion is seen. What is seen? T wave inversion along with a mild ST elevation. क्या दिख रहा है? Two findings are seen in lead 2. A mild ST elevation is seen. Along with that, we also can see a T wave inversion. This is also appreciated in lead 3. Okay, and this can also be appreciated in lead AVF. Okay, see ST elevation and T wave inversion. So these are the most important two findings, that is ST elevation and T wave inversion was seen. Right, along with that, myocardial infarction is also associated with bradycardia. Okay, so let's discuss few important points about this condition now. Okay, so in cases of myocardial infarction, which is a sequel of acute coronary syndrome. Okay, so for example, a patient is suffering from atherosclerosis, there is blockage in the coronary artery, due to which actually the myocardium is not receiving enough blood supply, there is ischemia. But during rest, the person is experiencing, the patient is not experiencing any symptoms. Only during exertion, the patient is experiencing symptoms. That is a case of chronic stable angina. When the symptoms start also at rest, that condition is known as unstable angina. And when that blockage is so much, more than 70%, okay, that leads to myocardial infarction, then that patient lands up in MI. Okay, and unstable angina and myocardial infarction are the two things which come under the diagnosis of acute coronary syndrome. Yaad rakh lena. So now what are the different features seen in cases of acute coronary syndrome or myocardial infarction, right? So on ECG, if we take of a MI patient, what can be seen? So सबसे पहले क्या दिखेगा? First of all, the myocardium is undergoing some injury, right, due to the decreased blood supply. So this injury, the ongoing injury is there, which can be appreciated with the ST elevation. Okay, which can be appreciated with this ST elevation. So the ST segments, it usually elevates within just minutes of the onset of cardiac chest pain. जैसे ही cardiac chest pain शुरू होता है, the ST elevation would occur within minutes of it. Okay. Next finding would be ischemia. And please remember, ST elevation is usually only seen in cases of ST elevated myocardial infarction. STEMI में दिखता है. Whereas in cases of N-STEMI, that is non-ST elevated MI में, there can be a normal ST segment or you can see a depressed ST segment. Okay. So ST segment depression can be seen in cases of N-STEMI. Okay, so first feature क्या था? ST elevation, which is occurring within minutes of it, minutes of injury. Next is your ischemia, that is decreased blood supply to the myocardium. So ischemia would be appreciated with this T wave inversion, and the T waves undergo full inversion by 24 hours. Okay, so the T waves invert fully within 24 hours of myocardial infarction. Next is your acute infarction का change दिखेगा. Okay, what can be seen over here? Usually a Q wave is a very smaller wave. Okay, so Q wave is less than 1/4 of the R wave. So R wave जितनी होगी ना उसका less than 1/4 would be a Q wave. But when this Q wave becomes more than 1/4 of the R wave amplitude, that would be known as a pathological or a deep Q wave. So please remember, a pathological or a deep Q wave would be broader in duration, that is more than equal to 0.3 seconds, or it would be more than 1/4 the height of the R wave. Okay, so that can be considered as a deep or a pathological Q wave, which is suggestive of acute infarction. And please remember, this deep Q wave will persist throughout life. कभी भी उस patient का ECG लोगे, then also you can find this deep Q wave on the ECG. And last is your old infarction. Okay, old infarction usually इसमें क्या दिखता है? The ST segments are usually normal. Okay, ST segments after a point of time when the injury subsides, the ST segment would also normalize. They will also come to the isoelectric line of the ECG. Okay, and the Q waves, they will remain forever. Right. So these are the usual changes which are seen in cases of ST elevated myocardial infarction. Okay. The image below also can show you some changes. First of all, this is a normal ECG. The person has started experiencing pain. Okay, within seconds or within some minutes only, the ECG shows us hyperacute T waves. Okay, so सबसे पहली finding क्या होगी? Hyperacute T waves. सबसे पहली finding क्या होगी? Hyperacute T waves are seen. Followed by ST elevation, which would be seen. ST segment elevation is seen. Third, there would be pathological Q wave or a deep Q wave which is seen, and within 24 hours there would be a fully inverted T wave. Okay, there would be a T wave inversion which is seen. Then followed by that the ST elevation would improve. Okay, the ST elevation would again come back to the isoelectric line, and lastly the T wave normalizes. Okay, and the Q wave forever persists. Okay, so याद रखना, only Q wave is the one which will forever persist on the ECG. Otherwise, the ST segment elevation also normalizes, and the T wave inversion also normalizes after a point of time in cases of myocardial infarction. I hope this is very clear to you, the ECG. Okay, now how to just recognize whether it is a lateral wall MI, anteroseptal wall MI, or an inferior wall MI. So for that, please remember which are the leads to be seen. That is very much important. So please remember, if these changes are seen in the lead 1 or V5 or V6 leads, which are lateral chest leads, so then it is considered to be a lateral wall myocardial infarction. Then it is considered to be a lateral wall MI. Lead 1 or V5 and V6, then it is considered as lateral wall MI. If the changes are seen in lead 2, lead 3 or lead AVF, F for foot का होता है नीचे, inferior. Therefore, in cases where the changes are seen in lead 2, lead 3 and AVF, then we can call it as a inferior wall MI. And in our question, the changes were seen in lead 2, lead 3 and AVF. Therefore, it can be diagnosed as an inferior wall myocardial infarction. And whenever the changes are seen in lead V1 to V4, whenever the changes are seen in lead V1 to V4, that can be diagnosed as an anteroseptal MI. That can be diagnosed as an anteroseptal MI. V1 and V2 are more specific for your septum, and V3 and V4 for your anterior wall. Okay, yaad rakhna, if you need to differentiate at any cost. So let's discuss some important points. If you guys would like me to discuss about other features of ECG, so we'll discuss some more important features that are seen on ECG and how to just diagnose them easily. So if you guys want me to, just let me know in the chat box, then I'll go with it. Okay, पहले तो normal sinus rhythm देख ही लो. Okay, so normal sinus rhythm में क्या देखना होता है? First of all, how to look for an ECG? Usually we prefer the second standard lead. Which is the best lead to look for? It is your second standard lead. उसमें क्या देखेंगे? There is a positive P wave. That means atrial contraction or depolarization is fine. Then there is a narrow QRS complex which is positive. That means the ventricular depolarization is also fine, and which is followed by a T wave, okay, which is positive again. That means again the ventricular repolarization is also fine. So there should be a P, narrow QRS and a T wave on an ECG. Then next we check for the rhythm, okay, and how to say it is a normal sinus rhythm. So please remember, if the RR interval, okay, RR interval अगर regular है, okay, for example this RR interval has 6 boxes in between them, this also has 6, this also has 6, so that means RR interval is equal throughout. That means there is a regular sinus rhythm, okay, there is a regular rhythm which is also known as a normal sinus rhythm, which is also known as a normal sinus rhythm. Okay, I'll go with the other forms of ECG too. Now next one, the next condition can be seen as sinus bradycardia. Bradycardia means less than 60 beats per minute of heart rate, right? So यहाँ पे क्या दिखेगा ECG में? Is there any pathology in the heart itself? No, there is no pathology. So there would be a positive P wave, narrow positive QRS complex and a positive T wave. Okay, उसमें कोई दिक्कत नहीं होगी. The only problem being the RR interval would be decreased. So for example, normally ये 6 था, so now it will become 8. Okay, so please remember the RR interval is regular. ठीक है, so the RR interval is same, that is 8, 8, 8, 8, but it has been increased in length. So please remember the RR interval when it lengthens, it is suggestive of sinus bradycardia. Next, sinus tachycardia means what? More than 100 beats per minute of heart rate. So in this, obviously all the other features, P wave, QRS complex and T wave are normal. Only the RR interval would be decreased and it would be regular again. ठीक है, मतलब पहले 6 था, so now it will become somewhat like 3 or 2, right? So now it has become 3. So in every RR interval it would be 3. So it is a regular rhythm, right? But only the RR interval has been decreased, that is suggestive of sinus tachycardia, right? Normal rhythm को sinus rhythm बोला जाता है, ये याद रख लेना बस. Next is your atrial fibrillation. So atrial fibrillation में atria में कोई भी दिक्कत होगी, whenever there is a pathology in atria, the changes would be seen in the P wave. That is very much clear, right? Atria में दिक्कत, P wave में changes. Ventricles में दिक्कत, QRS complex में changes. Easy to remember, याद रखना ये. So atrial fibrillation में क्या होगा? There would be a narrow QRS complex. See, here you can see a narrow normal QRS complex because there is no pathology in the ventricles. So QRS complex normally रहेगा obviously. The only problem is seen is between these QRS complexes. क्या दिख रहा है in between these QRS complex? Okay, there is just a fibrillating wave. ऐसी wave दिखेगी. Okay, so there is no proper P wave seen. There is only a fibrillating wave. I have already explained you atrial fibrillation में atria keeps on fibrillating. It is not able to contract properly, right? Therefore this fibrillating wave is seen in cases of atrial fibrillation. No positive P wave is seen and normal QRS complexes are seen. Along with that, मैंने क्या बोला था? Atrial fibrillation में there was irregular pulse as well as irregular rhythm on the ECG. So यहाँ पे देखो RR interval for example यहाँ पे 3 boxes है, यहाँ पे 2 है, यहाँ पे 2 है, यहाँ पे 3 है, यहाँ पे 1 है, यहाँ पे 2 है. So the RR interval is constantly changing. That means this is a irregular rhythm. This means it is a irregular rhythm. So please remember, irregular rhythm is seen in cases of atrial fibrillation. Next one is your atrial flutter. ठीक है, now atrial flutter में क्या होगा? RR interval would mostly be regular. Okay, RR interval normal रहेगा, उतना ही रहेगा. Okay, that would mostly be regular. Rhythm में कोई दिक्कत नहीं आएगी. The problem is over here. Again, P wave दिख रही है कि तुम्हें नहीं दिख रही, but this time the waves at least can be appreciated. The waves in between the QRS complexes are like this, just like the tooth of a saw. ठीक है, आरी के दांतों जैसा है. So therefore in cases of atrial flutter, saw tooth appearance is seen on the ECG. क्या दिखता है हमें? Saw tooth appearance is seen on the ECG. Please remember, saw tooth appearance is seen on the ECG in cases of atrial flutter. Okay, please remember this. Next one is your supraventricular tachycardia. Supraventricle मतलब ventricles के ऊपर. That is again the pathology lies in the atria. So this is your supraventricular tachycardia. So here again the QRS complexes are normal, right? Because there is no pathology in the ventricles. Okay, just between the QRS complexes, what you can see, you can just see a T wave. यहाँ पे क्या दिख रहा है? Only a T wave is seen. P wave कहाँ गायब हो गई फिर? So please remember the P wave is hidden. Okay, so the heart rate is increased because there is tachycardia. So there is narrow RR interval. See, RR interval कम हो गया. So there is a narrow regular RR interval which is seen, but therefore the P wave is actually hidden in beneath the QRS complexes. So P wave कहाँ चली जाती है? Just beneath the QRS complexes. Okay, so it is hidden by the QRS complexes. So please remember, in cases of supraventricular tachycardia, there would be a hidden P wave along with increased heart rate which can be seen. Next is your premature atrial contraction. Now premature atrial contraction मतलब क्या होता है? Atria time से पहले ही contract कर जाता है. Okay, suddenly at any point of time. That is known as premature atrial contraction. So atria में दिक्कत होगी तो कौन सी wave effect होगी? Again P wave effect होगी. So please remember, यहाँ पे normal P wave, normal QRS complex, but here you can see a very high what you can see over here, a T wave can be seen. Next again a P wave QRS complex. Here you can see just a T wave. आगे की P wave दिख रही है क्या? नहीं, because please remember the P wave is actually beneath this T wave. Both of them have coincided. Both of them have coincided and that has made it a larger in amplitude T wave, okay, बड़ी सी T wave दिखेगी. That is not suggestive of hyperkalemia. मैं पहले ही बता रहा हूँ. This is not suggestive of hyperkalemia. It is just because that the atria has contracted before time and therefore T wave और P wave मिल चुकी है and that has lead to this increased amplitude of T wave. Okay, याद रखना. This is seen in cases of premature atrial contraction PAC, which is not commonly asked, not a common phenomena though. Next is your premature ventricular contraction, which is common. That is also known as extrasystole, PVC or premature ventricular contraction or extrasystole. इसमें क्या होता है usually see normal P wave, normal QRS complex and a normal T wave is seen. But what you can see over here there is just a broad QRS complex. Broad QRS मतलब there is pathology in the ventricles, right? So here you can see a broad QRS complex, which is actually the ventricles are contracting before time. Okay, so regular RR interval चल रहा है, उसी के बीच में you can see a abnormal QRS complex that is suggestive of premature ventricular contraction or PVC or extrasystole. Next is your ventricular tachycardia. So VT में क्या होता है ये ventricular tachycardia में? Again the pathology lies in the ventricles. Therefore there would be broad and abnormal QRS complexes. So see over here you can see inverted QRS complexes almost, right, which are broader in size. So that means there is some pathology in the ventricles. And along with that, what can be seen? The RR interval has been reduced. That means it is suggestive of tachycardia. And as there is pathology in the ventricles, so this can be counted down to as ventricular tachycardia. Okay, this can be counted down to as ventricular tachycardia. Please remember, यहाँ पे क्या दिख रहा है? The size and the shape of the QRS complexes which are seen, they are same throughout. ठीक है? See, the size and shape of the QRS complexes are same throughout. एक जैसे दिख रहे हैं, right? So please remember, this condition is known as monomorphic ventricular tachycardia. एक size and एक shape. So this condition is known as monomorphic ventricular tachycardia. But on the other hand, if we can see something like this, okay, something like this, I have already explained to you in the last session, if the shape and size of the QRS complexes vary, okay, and there is tachycardia, so that is known as which type of ventricular tachycardia? That is known as polymorphic ventricular tachycardia. This condition would be known as polymorphic ventricular tachycardia. Different size and different shapes of the QRS complexes. Can anybody tell me polymorphic VT is also known as which condition? Polymorphic VT is also known as which condition? This we have already discussed. Next, last condition is your ventricular fibrillation. See, in cases of ventricular fibrillation, guys, usually the ventricles are just fibrillating. They are not able to contract properly. अगर वो contract ही नहीं करेंगे properly, if they are not depolarizing properly, therefore QRS complexes would not be generated. So here there would be just abnormal QRS complexes. ये तो better है. There can be a sine wave rhythm. So this is just a sine wave rhythm which can be seen. Just a fibrillating wave can be seen. A sine wave rhythm it is called as. And therefore in cases of ventricular fibrillation, as the cardiac output is almost reduced, the patient is in shock or the patient can be hemodynamically unstable. And therefore in cases of VF, we usually give what? Electrical cardioversion with 200 joule biphasic shock, non-synchronized, because R wave peak is not seen at all. Therefore a non-synchronized shock is to be given. Whereas in cases of ventricular tachycardia, we can give a synchronized DC shock. Okay, याद रख लेना. Anybody, what is the condition known as? Polymorphic ventricular tachycardia. This is known as torsades de pointis. क्या बोलेंगे? TDP, torsades de pointis. Drug of choice being magnesium sulfate. Okay, please remember this. Don't forget it. It is very important. Okay. Moving further, guys, to our next one. Yes, very good, Adak. Now moving next one. Heart block का देख लो बस एक बार ECG, then we'll move further to our next question. So now it is very important, heart block. Okay, so now talking about first degree heart block. So in first degree heart block, what can be seen? See over here, P wave is positive, normal QRS complex, normal T wave. So there is no pathology in this. Next, what can be seen? Usually the PR interval, मैंने कितना बोला था? Normal PR interval is between 0.1 to 0.2 seconds. Okay, so the normal PR interval is between 0.1 to 0.2 seconds, right? But if the PR interval is more than 200 milliseconds or more than 0.2 seconds, then it is known as prolonged PR interval. And usually in cases of first degree heart block, we can say this prolonged PR interval. ठीक है? Every time it is the same. For example, it is 240, it is 240, it is 0.240. Okay. More than 240 milliseconds, more than 240. Okay. So याद रख लेना. So it is 240 every time. So the PR interval is fixed, but it is prolonged. PR interval is fixed, but it is prolonged, which is seen in cases of first degree heart block. Next, in second degree heart block. Second degree heart block is usually divided into type 1 and type 2. So type 1 is also known as Mobitz type 1 or Wenske-Bach heart block, whereas type 2 is also known as Mobitz type 2 heart block. So what is the difference between both of these? So in second degree heart block type 1, usually there would be a progressive prolongation of the PR interval. So the PR interval is prolonged, means it is more than 0.2 second always, but there is progressive prolongation. Matlab, for example, here it was 0.21, here it is 0.23, here it is 0.27. Okay, so there is progressive prolongation of the PR interval. Along with that, in between there would be a dropped QRS complex. It is also known as a drop beat. Okay, so there is progressive prolongation of PR interval along with a drop beat, which is suggestive of Mobitz type 1 second degree heart block. Next is your Mobitz type 2 second degree heart block. In this, what can be seen? In this, you can see dropped QRS complex. Okay, so here only a drop beat can be seen, but the PR interval is fixed. Okay, so please remember, PR interval is not progressively prolongating, it is just fixed. 0.24 to 0.24 is throughout. Okay, only you can see drop beats in between. Okay, next, last one is your third degree heart block, which is also counted to as complete heart block. In third degree heart block, usually what happens here, the atria and ventricles अपने ही धुन में चल रहे हैं. Okay, so the atria are contracting individually and the ventricles are contracting individually. Okay, there is no coordination in between these two. Therefore, the PP intervals would be regular. Okay, please remember, there would be regular PP intervals because atria is contracting at its time, but it is not in relation to the ventricles. So there would be regular PP intervals and regular RR intervals too, because QRS is also produced. Okay, and ventricles are also contracting regularly, but both of them are not in coordination. So here you can see the P wave after the QRS complex. Okay, see. So is it of any use? No, it is not. It is of it is not of any use, right? Please remember this. Just a minute, guys. Sorry. So I hope this is clear to you. First degree, second degree and third degree heart blocks, right? And T wave morphology में tall tented T waves are usually seen in cases of hyperkalemia. T wave inversion is usually seen in cases of ischemia. ये important है, याद रख लेना. Now, yes, to our question again. So here the answer was option D, ischemic myocardial infarction in the inferior wall, because याद रख लेना, it was a young adult man. Okay, chest pain था, usually a Levine sign is seen. That is, the patient points towards the chest pain as with a closed fist. Okay, यहाँ दर्द हो रहा है मेरे. So that is the history usually given. Okay, he has a history of smoking, and as we all know, smoking almost is a very important risk factor for your atherosclerosis or your coronary artery disease, right, which is a predisposing factor for MI definitely. Okay, then there is a family history again. Bradycardia seen, sinus bradycardia, along with that ST elevation and T wave inversion seen on the second, third and AVF lead, suggestive of inferior wall MI. Moving further to our next one. So question number 21. It states a 65-year-old female presents with persistent headache, pain in the jaw while chewing, blurring of the vision and diplopia. Diplopia means double vision. The incorrect statement about the following condition is. So you need to find the incorrect statement, the false statement. So all the statements are true except one that we need to find. Okay, this question can be framed in other way also. Please remember this, right? So now let's see, guys, what is the diagnosis. Can anybody tell me what is the provisional diagnosis in this condition? Can anybody tell me this? What is the provisional diagnosis? A elderly female presenting with persistent headache, pain in the jaw while chewing. Okay, there is blurring of vision and diplopia. Any probable diagnosis? So let's see the options first if you are not coming to the diagnosis. Option A, histopathology reveals multinucleated giant cells. Option B, best investigation is MRI. Option C, biopsy is recommended for the diagnosis. Option D, it is the most common vasculitis in adults. So easy हो गया option पढ़ के. कभी कभी this is the thing that you find some hint in the options itself. So please remember, they are actually asking for some type of vasculitis, right? They are asking for some type of vasculitis. Now अभी दिमाग तुम्हारा पूरे vasculitis के आसपास घूमने दो. Can anybody tell me? Yes, very good Uma. So the answer over here would be option C. Can anybody tell me what is the probable diagnosis? But can anybody tell me what is the provisional diagnosis in this condition? Which is the vasculitis which is common in elderly females, which presents with persistent headache, Yes, very good, Moria. It is giant cell arteritis or temporal arteritis. Yes, it is GCA, giant cell arteritis, also known as temporal arteritis. Important one. Okay, so please remember, usually giant cell arteritis is common in more than 50-year-old females. कितने में? So elderly females, more than 50-year-old में it is common. Okay, then it usually involves the vessels of the face, neck or the head. Okay, so please remember, it usually involves these vessels, and the most common vessel involved, so please remember, the most common vessel involved in GCA is your superficial temporal artery. So please remember, the most common vessel involved is your superficial temporal artery in this condition. Therefore it leads to temporal headache. Okay, commonly GCA presents with temporal headache. Okay, which is the most common symptom. So please remember, this leads to temporal headache, which is the most common symptom. Headache is the most common symptom. But if they ask about most specific symptom, so please remember the answer would be jaw claudication. यहाँ पे क्या बोला है उन्होंने? Pain in jaw while chewing. So that is suggestive of jaw claudication, which is the most specific symptom. So please remember, jaw claudication is the most specific symptom of GCA. याद रख लेना. Most specific symptom of GCA is your jaw claudication. Okay, along with that, there would be a feared complication like blindness, which can be associated with GCA, but it usually starts with diplopia or double vision. Please remember. And this jaw claudication, as we all know guys, because temporal artery would supply the masticatory muscles, and therefore while chewing there would be pain in the jaw. That is known as jaw claudication, right? याद रखना, GCA is the most common type of vasculitis in adults. It is the most common type of vasculitis usually seen in adults. Yeah, I hope the connection has been proper now again. So please remember, the biopsy is not recommended, but for research purposes we have performed biopsies right earlier. So in that we have seen usually multinucleated giant cells. Okay, the best investigation for this condition will usually be a MRI. We are not performing any invasive investigation, therefore the best investigation would be a MRI. Okay, if they ask about gold standard investigation, that would be a biopsy. The gold standard investigation would be a biopsy, but as we all know guys, gold standard investigations are theoretical most of the times. They are not practical. Investigation of choice or best investigations are usually practical. Gold standard was theoretical investigations होते हैं, which are usually not practiced in the clinics, right? So please remember. Along with that, there would be, as this is an inflammatory condition, there would be elevated ESR more than 100 millimeter per hour. Okay, this is a very characteristic finding. And the treatment of choice, again, as this is an autoimmune condition guys, therefore the treatment of choice in this condition would be what? Steroids. Please remember this. Okay, and yeah, I hope this is clear to you now. Moving on to our next question, that is question number 22, which states a 19-year-old male sprinter means fast runners जो होता है, right? A 19-year-old male sprinter suddenly collapsed during a 100-meter sprint. He was rushed to the hospital where he was declared dead. Family gave history of similar death in his sibling. The most likely diagnosis is, can anybody tell the answer? Option A, restrictive cardiomyopathy. Very good, Nidhi. The answer over here would be hypertrophic cardiomyopathy. Very good. Super fast, yeah? Hypertrophic cardiomyopathy. Easy to diagnose. Let's see what are the features to diagnose it as HOCM. Okay, so first of all, talking about HOCM, that is hypertrophic obstructive cardiomyopathy. ठीक है, इसमें क्या होता है usually? These are your ventricles. So in the left ventricle at the septum, there would be hypertrophy. There will be hypertrophy of the septum. Okay, so you can see over here there is hypertrophy of the septum, and here is where the aorta arises from. So therefore the aorta would the blood flow in the aorta would be obstructed. Okay, so there would be hypertrophy of the septum leading to ischemia, leading to decreased blood flow in the aorta due to the obstruction which is created. So this is a condition of hypertrophic obstructive cardiomyopathy, which is a genetic condition which is inherited from one generation to the another, and the pattern of inheritance is autosomal dominant. The pattern of inheritance of HOCM can be asked. It is autosomal dominant. Which gene is mutated? It is your beta myosin gene is mutated. Please remember, beta myosin gene mutation occurs, which is located on chromosome number 14. Please remember this. Okay, so HOCM, how it would clinically present to us? So there would be a young male with a history of sudden cardiac death. Commonly HOCM would present to us a young male present to us with a history of sudden cardiac death, or there would be dyspnea on exertion, there would be palpitation, all of these symptoms would be seen. Okay, or the patient would be unconscious. Then there would be pulsus bisferiens. Okay, two peaks in the systole would be seen on the pulse. So So there would be pulsus bisferiens. Then there would be a heaving apex. Heaving matlab a very stronger beating apex. Okay. So when you palpate the apex, you can feel a very stronger apex. Then there would be a crescendo decrescendo murmur. This crescendo means rising and decrescendo means decreasing. So a rising and a falling, crescendo decrescendo murmur would be seen. Okay. Along with that, drug of choice would be what? Drug of choice in this condition would be propranolol. Propranolol is a non-specific beta blocker. So please remember, beta blockers will usually block the beta 1 receptor, decreasing the heart rate, and as the heart rate is decreased, the myocardial oxygen demand is also decreased. ठीक है, so myocardial को अभी ऑक्सीजन कम लगेगा, therefore the patient would not land up in myocardial infarction, or that patient would not land up into death immediately. Okay, because the work on the heart is decreased. Okay, so that is the reason why propranolol is considered the drug of choice in cases of HOCM. Next, the treatment of choice would be what? ये तुम्हें हटाना है. So how we will remove it? So please remember, you will ablate this hypertrophied septum, and this hypertrophied septum can be ablated by a treatment known as alcohol septal ablation. The treatment is known as alcohol septal ablation, which is the treatment of choice for HOCM. The ECG would reveal what? So what happens? As there is increased workload on the left ventricle now, because the blood is not going out from the aorta due to this obstruction. Therefore, blood is keeping on accumulating in the left ventricle. That is increasing the workload on the left ventricle, leading to left ventricular hypertrophy. So LVH would be seen, and LVH on ECG can be diagnosed as. So please remember, LVH कैसा देखना होता है? So the R wave in V1 lead and the R wave in V5 lead together, if added, they will make a sum of more than 35 mm. Okay, so please remember, the amplitude of R wave in V1 lead along with amplitude of R wave in V5 lead, if added together, the total would be more than 35 mm, and this can be diagnosed as LVH or left ventricular hypertrophy. As we all know, one large box is 5 mm, therefore you can also say that is more than 7 boxes agar hote hai, then also that condition can be called as left ventricular hypertrophy. And as we all know, LVH is very non-specific, therefore ECG cannot be the investigation of choice, because LVH can be seen in multiple other conditions, right? So therefore the investigation of choice in this condition would be a echocardiography. The condition would be the investigation of choice in HOCM would be a echocardiography, which will show us this hypertrophied septum along with this banana shaped cavity. Cavity कैसी हो गई है? Banana shaped cavity would be seen, right? Important one. Metoprolol is a cardioselective beta blocker which can also be given. Okay, please remember, it can also be given. So please remember this. It can also be given. Propranolol is a better drug to be given because it is non-specific. Then talking about restrictive cardiomyopathy or RCM, it is the rarest form of cardiomyopathy. So please remember, restrictive cardiomyopathy or RCM, it is the rarest form of cardiomyopathy, and the most common cause of restrictive cardiomyopathy would be amyloidosis. The most common cause of restrictive cardiomyopathy would be amyloidosis. So what happens usually in restrictive cardiomyopathy? The heart is not able to contract properly because the walls or the myocardium of the heart has been stenosed, or there is some deposition in this heart which is not actually letting the heart to contract properly. Okay, this can be usually seen in cases like most commonly in amyloidosis, also in other deposition disorders, okay, like hemochromatosis as well. So please remember, usually restrictive cardiomyopathy, the most common cause is amyloidosis. Investigation of choice, here you need to check for the walls of the heart. Therefore, the investigation of choice for RCM would be cardiac MRI. Investigation of choice for RCM would be cardiac MRI. Please remember. Echocardiography would show us a square root wave sign. So this is what a square root wave looks like. Okay. So echocardiography of RCM will show us a square root wave sign. ECG will be low voltage. Okay, so please remember, ECG would be low voltage. छोटे छोटे waves दिखेंगे. Okay, there would be a low voltage ECG. Okay, and low voltage ECG are usually seen in conditions known as PCM. Mnemonic क्या है? PCM. So low voltage ECG are usually seen in PCM. P goes for pericarditis. Which type of pericarditis? Constrictive pericarditis. C goes for cardiomyopathy. Which type of cardiomyopathy? RCM, restrictive cardiomyopathy. And M goes for myxedema coma. So constrictive pericarditis, restrictive cardiomyopathy and myxedema coma will all show us a low voltage ECG. Now treatment for RCM would be oral diuretics and anticoagulants, as the peripheral vascular resistance would also be increased because this deposition would also occur in the vessel walls, right? So please remember, therefore to decrease the blood pressure, usually we give oral diuretics along with anticoagulants. The treatment of choice for RCM would be cardiac transplantation. Okay, finally we need to transplant the heart. Now the third type of important cardiomyopathy is dilated cardiomyopathy, when the ventricles of the heart would be dilated. Okay, so there is dilated cardiomyopathy and this would lead to systolic dysfunction. The heart would not be able to contract fully. Okay, इस तरह से contract करेगा, इस तरह से. Okay, so please remember that is usually seen in conditions of dilated cardiomyopathy, for which the most common cause is alcohol. Okay, so please remember the most common toxin leading to DCM is alcohol. Please remember alcohol intake is commonly associated with dilated cardiomyopathy. Investigation of choice would be a echocardiography, on which we can see a dilated ventricle. Treatment would be a cardiac transplant, or in conditions we can also put a implantable cardioverter defibrillator, ICD, implantable cardioverter defibrillator, which will defibrillate the heart. Defibrillation में क्या होता है? The heart comes to a standstill with a shock, and then again the heart starts new. Okay, heart again beat करना शुरू कर देता है नए तरीके से, right? So then moving further to a murmur which is seen usually in cases of dilated cardiomyopathy, we can see a pan-systolic murmur. Okay, because the heart is not able to contract properly and the valves are separated due to dilation, so there would be regurgitation occurring, and this regurgitation would lead to pan-systolic murmur. Okay, I hope this is clear to you, and the answer to this question number 22 was option D, hypertrophic cardiomyopathy. Moving further to our next question, question number 23. All the below given statements are true about the pathological changes seen in myocardial infarction except. So they are asking about the false statement. सबसे पहले तो ये पता लगा लिया करो कि what actually they want to ask you. Okay, so please remember यहाँ पे क्या बोला है? All the statements are true except one. So that one statement would be false. That we need to find out, right? So now option A, they say the earliest light microscopic change is VV fibers. The earliest light microscopic change would be VV fibers. Yes, this statement is true. So please remember the earliest change which is seen on a light microscopy would be this VV fibers. Okay, so fibers like this would be seen. VV fibers are seen usually on the light microscopy of the biopsy after an MI. Okay, that is usually seen after 4 hours. Okay, that is usually seen after 4 hours. Next, option B, they say contraction band necrosis occurs around 3 to 7 days. So please remember, can anybody tell me contraction band necrosis usually occur around how many days? So contraction band necrosis is the most specific finding of myocardial infarction. Contraction band necrosis is a very specific finding of MI. Eosinophilic contraction bands are usually seen. So for example, this is your myocardium, these are your eosinophilic contraction bands. And these eosinophilic contraction bands are usually seen between 1 to 3 days. याद रख लेना, these are usually seen between 1 to 3 days. Okay, important है ये. Next, mitochondrial swelling on electron microscope is seen within 30 minutes. Yes, the earliest electron microscopic change is fast. Okay, earliest electron microscopic change would be mitochondrial swelling, because the cell is undergoing injury and we have already studied cell injury. So cell injury में क्या होता है? There is mitochondrial and cell swelling which occurs. So in this condition also there would be a mitochondrial swelling which can be seen on an electron microscopy, and it occurs only within 30 minutes. Okay, as early as 30 minutes the mitochondrial swelling would occur. Next, option D, macrophages appear along with coagulative necrosis within 12 to 24 hours. So please remember guys, contraction band necrosis can also occur late in the course, that is 3 to 7 days. So this statement can also be true, like contraction band necrosis can occur around 3 to 7 days also. But last statement, that is macrophages appear along with coagulative necrosis within 12 to 24 hours. Yes, it is important that coagulative necrosis is usually seen in myocardial infarction and that occurs within 12 to 24 hours. But are macrophages seen along with coagulative necrosis? Can anybody tell me? Are macrophages the earliest blood cells to be seen in site of inflammation? As we have already discussed, in cases of acute inflammation, what are the blood cells to be seen? Macrophages are just modified monocytes, right, usually, and monocytes, lymphocytes or macrophages are usually seen in chronic phase of a disease, and these macrophages usually come over 3 to 7 days period, and they will replace which cells? Can anybody tell me? They will replace the earliest blood cells which come in cases of acute inflammation. And which are the blood cells which come in cases of acute inflammation? Can anybody tell me this? So please remember, these are usually your neutrophils. याद रख लेना, neutrophils are the earliest cells which come at the site of inflammation. So option D would be your wrong answer. That is your false statement. Okay, if they would have given that neutrophils appear along with coagulated necrosis within 12 to 24 hours, then option B would have been marked as wrong. Okay, moving further to a question number 24. Here they say a 49-year-old female patient presented with exercise intolerance, dyspnea on exertion, chest tightness, and repeated episodes of fever. And elevated C-reactive protein. As we have already discussed, C-reactive protein and ESR are the two most important acute phase reactants which usually increase in the cases of inflammation. Right? So there is elevated CRP. Auscultation reveals a plop sound. Echocardiography reveals decreased left ventricular ejection fraction, LVEF, and a mass which is seen in the left atrium which is prolapsing in the left ventricle during diastole. The histopathological examination on resection of the mass is given below. The likely diagnosis is, yes, all of you are right. The answer to this question would be option C, that is atrial myxoma. So what are the features? As we all know, guys, atrial myxoma is the most common cardiac tumor which usually is seen in adults. So please remember, if the question is which is the most common primary cardiac tumor, so the answer should be atrial myxoma. Which is the most common primary cardiac tumor? The answer should be atrial myxoma. So in adults, the most common primary cardiac tumor would be atrial myxoma. Can anybody tell me which is the most common primary benign cardiac tumor in children? Which is the most common primary benign cardiac tumor seen in children? Benign I am asking, ठीक है, ये याद रख लेना. Benign I am asking, ये याद रखना important है. Okay, so in the meanwhile we'll discuss about atrial myxoma, guys. So please remember, in atrial myxoma what can be seen? The histopathological examination is given. You can see a myxoid background. Okay, यहाँ पे क्या दिख रहा है? एकदम myxoid, एकदम पूरा mix हुआ हुआ background दिख रहा है, right? There is a plain background. There are no appreciable cells वगैरह seen properly. Okay, so this is a myxoid background with some lymphocytic infiltrate. ये जो blue करके ज़्यादा दिख रहे हैं ना, these are usually your lymphocytic infiltrates which can be seen in cases of atrial myxoma. So a myxoid background along with lymphocytic infiltrate usually is seen on histopathology. So atrial myxoma is the most common type of cardiac tumor in adults. So here the question mentions that there is a 49-year-old female patient presenting with exercise intolerance, dyspnea on exertion, and chest tightness. All of these features are seen in atrial myxoma. Along with that, there are repeated episodes of fever and elevated CRP also. Okay, and most important, that the auscultation reveals a plop sound. This is also known as a tumor plop sound. Okay, due to the ball and switch mechanism, there is a tumor plop sound heard on auscultation. Tumor plop sound. Okay, echocardiography reveals decreased left ventricular ejection fraction. Okay, as the mass is obstructing the outflow. Right, important one. So that is all the features are suggestive of atrial myxoma. Please remember, the most common benign cardiac tumor in children, yes, you are right, Adak, half of it was right, that it is a rhabdomyoma. Yaad rakh lena, it is a rhabdomyoma. I have already explained in the video of neoplasia. You can refer to that video. Here there only is OMA referred to as, that is referred for a benign tumor. So rhabdomyoma is the most common primary cardiac tumor seen in cases of children. If they ask the most common primary malignant cardiac tumor seen in children, then the answer would be rhabdomyosarcoma, because sarcoma suggests a malignancy. If the question would have been most common primary malignant cardiac tumor in children, then the answer would have been cardiac rhabdomyosarcoma. Yaad rakh lena. Okay, so I hope this was clear to you. Moving further to our question number 25. A 70-year-old male came into the OPD due to 6 weeks of progressive dyspnea. Okay, the dyspnea is progressing. He had a non-productive cough, that is a dry cough, for 4 months now. He worked in an asbestos mining industry for 40 years. So there is a history of asbestos exposure for almost 40 years. Yaad rakhna. Upon physical examination, there are decreased breath sounds. There is decreased breath sounds, and dullness on percussion is seen at the base of the left lung. At the base of the left lung. Normally on percussion we find resonance, ठीक है? And whenever there is pneumothorax, there would be hyper resonance, right? याद रखना, pneumothorax में हमेशा there would be hyper resonance because air will lead to resonance. So ज़्यादा air होगी, obviously there would be hyper resonance. Dullness would be found on percussion in cases of whenever there is fluid accumulation, like in cases of pneumonia हो गया, or in cases of pleural effusion हो गया, right, or in cases like any mass which is there, like any cancer or any other mass which can be seen. In these cases there would be dullness, right. So there is decreased breath sounds and dullness on percussion at the base of the left lung. Important, there is base of the left lung involvement. Chest CT scan reveals a left-sided pleural effusion and a diffuse nodular thickening of the pleura. So there is some pathology related to the pleura. Okay, pleural effusion bhi hai or nodular thickening of the pleura is also seen. Lung parenchyma is intact, so there is no pathology in the lung parenchyma. What is the probable diagnosis? So please remember guys, the answer over here would be very good. The answer over here would be option D, malignant mesothelioma. Okay, please remember, मैंने क्या बोला अभी, the lung parenchyma is intact and all these tumors whichever are there, all of these are lung parenchymal tumors. So यहीं पे rule out हो जाता है. Okay, यहीं पे all of these are ruled out. Now let me explain you one by one कैसे rule out करना है. याद रखना, first of all, small cell carcinoma, it is usually associated with the smoking history. So there is a very strong association of small cell carcinoma along with smoking history. There is no smoking history seen. Okay, ठीक है, no issues. But along with that, small cell carcinoma usually involves the peripheral part of the lung. Okay, it usually involves the peripheral part of the lung, and here pleura is involved, not the peripheral parenchyma. Okay, so peripheral parenchyma is affected in cases of small cell or old cell carcinoma of lung. Here the parenchyma is totally intact, so definitely small cell carcinoma can be ruled out. Next is your squamous cell carcinoma, again a strong association with smoking, and the second finding being that there is a central parenchymal involvement. Again क्या होता है, there is a central parenchymal involvement. So यहाँ पे parenchyma involved है, so one of the feature to rule it out. Second, central involvement है, और यहाँ पे क्या दिखा रहा है, left sided pleural effusion and diffuse nodular thickening of the pleura. So lateral involvement is seen, no central involvement is seen. So again squamous cell carcinoma can be ruled out. Last is your carcinoid lung tumor. Carcinoid lung tumor are usually neuroendocrine lung tumors. In lung they usually arise from the Clara cells. Okay, they usually arise from the Clara cells. Important है Clara cells, याद रख लेना ये, ठीक है. So what happens usually in cases of carcinoid lung tumors? So please remember, in carcinoid lung tumors, they are the rarest form of tumors. Okay, they are usually the rare form of tumors which are seen, but if they occur, they commonly occur in the primary or secondary bronchioles. So there are bronchial carcinoids which are very common. Okay, again bronchus is located at the center of the lung, so again here there would be central involvement which is not seen in the question. Therefore the carcinoids can be easily ruled out. Along with that, और अगर ये सब रूल आउट नहीं करना है, so the question has a very important hint. क्या बोला उन्होंने, non productive cough, progressive dyspnea. Along with that there is a asbestos exposure for 40 years. So this is a occupational lung disease, that is a pneumoconiosis known as asbestosis. And if anybody of you can recall, asbestosis is commonly associated with a lung cancer known as malignant mesothelioma. याद रखना, mesothelium मतलब क्या होता है, it is the lining of your serous cavities like your pleural cavity, pericardial cavity, peritoneal cavity. Okay, अगर उसका कोई भी ट्यूमर होता है, any tumor of the pleural, pericardial or the peritoneal cavity, it can be termed to as mesothelioma. Okay, so here the condition is malignant mesothelioma, and I have already explained you there is pleural pathology, and malignant mesothelioma is a tumor of your what, pleura, right? So there is pleural effusion and diffuse nodular thickening of the pleura seen on the CT scan of the chest. Okay, important. So now let's discuss some important points about these three important pneumoconiosis, that is asbestosis, silicosis and coal workers pneumoconiosis. Coal workers pneumoconiosis also known as anthracosis, याद रखना. Right, so asbestosis usually it affects the lower lobe. Asbestosis usually affects the lower lobe, which was the condition in our case also. It was discussed that the left lower lobe was affected, so it was easy again. So the lower lobe is affected commonly, whereas in silicosis and CWP, upper lobes are commonly affected. Then the chest X-ray of asbestosis would show us apical nodular shadow. Along with that there would be pleural thickening, which can lead to the formation of pleural plaques also. Okay, and pleural plaques are the most characteristic finding of asbestosis on a chest X-ray. Which is the most characteristic finding of asbestosis on a chest X-ray? Those are your pleural plaques. याद रखना. Then asbestosis is commonly associated with, so please remember, if they ask you the most common association of asbestosis, then the answer would be adenocarcinoma or bronchogenic carcinoma. याद रख लेना कौन सा कैंसर कॉमन है, adeno or bronchogenic carcinoma. Okay, please remember the most common disease associated with asbestosis, the answer would be adeno or bronchogenic carcinoma. Whereas if they ask the most specific cancer associated, then the answer would be malignant mesothelioma. If they ask the most specific one, answer is malignant mesothelioma. If they ask the most common one, answer is adeno or bronchogenic carcinoma. Then in cases of silicosis, upper lobe is commonly affected. On a chest x-ray, usually you will find snowstorm appearance, and this snowstorm appearance is usually due to this reticulonodular opacities. What is seen throughout the lung? Throughout the lung we can see these reticulonodular opacities giving us a snowstorm appearance on the chest x-ray. कौन सा appearance on chest x-ray? Snowstorm appearance on the chest x-ray in cases of silicosis is seen. Along with that we can find eggshell calcification on the chest x-ray. Along with that there would be hilar lymphadenopathy. There would be hilar lymphadenopathy, that is the lymph nodes which are located at the hilum of the lung, they would be enlarged. So there would be enlargement of the hilar lymph nodes. Okay, can anybody tell me a rheumatic condition है, rheumatology से condition है, there would be bilateral hilar lymphadenopathy in a young adult female. Okay, in a adult female, middle-aged female usually, bilateral hilar lymphadenopathy in a middle-aged female along with erythematous rash on the face. Can anybody tell me a diagnosis over here? This is just for more extra age information. Okay, याद रखना. Then coming back to silicosis, silicosis में please remember the most common disease associated is tuberculosis. Silicosis is most commonly associated with TB. Therefore, it is commonly known as silicotuberculosis. Next one is your cold-workers pneumoconiosis, also known as anthracosis, in which again the upper lobe is affected commonly, and in this we can see progressive massive fibrosis. Okay, and the disease associated with this condition is known as Kaplan syndrome. The disease associated is known as Kaplan syndrome. That means there is a combination of cold-workers pneumoconiosis along with rheumatoid arthritis. CWP along with rheumatoid arthritis together is known as Kaplan syndrome. No bilateral hilar lymphadenopathy in a middle-aged female I am asking, not in a young female. I am asking a middle-aged female along with erythematous rash on the face. Bilateral hilar lymphadenopathy is the most characteristic chest x-ray finding of sarcoidosis, guys. याद रख लेना, bilateral hilar lymphadenopathy is the most characteristic chest x-ray finding of sarcoidosis, which is seen in middle-aged females. Along with that there is a erythematous rash on the face. That rash is known as lupus pernio, which involves the nasolabial folds. It involves the nasolabial folds, याद रखना. It does not spare the nasolabial fold, unlike SLE. Moving further to our question number 26, that states a 35-year-old male presents to the OPD with fever for 2 weeks now. There is non-productive cough and there is a significant weight loss. Okay, his past medical history revealed he has HIV. So it is a person of HIV/AIDS. He is a non-smoker and a non-alcoholic by nature. Chest X-ray is given below. What is the probable diagnosis? What is the probable diagnosis? याद रखना guys, not always erythematous rash can be SLE. Please remember there is a very close differential diagnosis known as sarcoidosis, जिसमें SLE में क्या होता है, एक basic difference याद रख लेना. SLE में the nasolabial folds are not involved, whereas in lupus pernio of sarcoidosis the nasolabial folds are also involved. याद रखना, ये important है. Okay. Yes, very good Nirali. The answer over here would be option C, Pneumocystis jirovecii pneumonia. Okay, yes, the answer over here is option C, Pneumocystis jirovecii pneumonia. Okay, so please remember in Pneumocystis jirovecii pneumonia, here is the chest x-ray. Usually you will find a perihilar involvement. Okay, at the around the hilum the involvement would be common. Okay, so there would be commonly a perihilar involvement would be seen. Which involvement? A perihilar involvement is seen. You can see some reticulonodular opacities along with this. Okay, so please remember there would be a perihilar enhancement which is usually seen in cases of Pneumocystis jirovecii pneumonia. But इससे easy कैसा ये करना है diagnosis? एक तो first of all a young adult male presenting with fever, 2 weeks of non-productive cough, significant weight loss. Okay, ये सब ठीक है. That is common to many of the lung infections. But most important क्या है? He is a diagnosed case of HIV/AIDS. This person is a diagnosed case of HIV/AIDS, right? So, and as we all know that the most common opportunistic infection in cases of HIV is what? the most common opportunistic infection in cases of HIV is Pneumocystis carinii or Pneumocystis jirovecii pneumonia. Pneumocystis carinii or jirovecii pneumonia, which is the most common opportunistic infection associated with HIV worldwide. मैं क्या बोल रहा हूँ? Worldwide. If the question is most common opportunistic infection seen in cases of HIV positive individuals in India, okay, in Indian population, then the answer would be what? Tell the answer to this question. Till that I'll discuss other opportunistic infections which are important from medicine point of view. So याद रखना, usually Pneumocystis carinii or jirovecii pneumonia is the most common opportunistic infection seen in HIV positive individuals at a CD4 count of less than 200 cells per cubic millimeter. At a CD4 count of less than 200 cells per cubic millimeter. Okay, so opportunistic infections are common when the CD4 count goes below 500 cells per cubic millimeter. Okay, याद रखना, opportunistic infections are common when the CD4 count goes below 500 cells per cubic millimeter. Less than 200 cells per cubic millimeter, PCP is common, which is the most common opportunistic infection. Okay, less than 100, toxoplasmosis is common, toxoplasmosis, and less than 50 cells, CMV retinitis is common, that is cytomegalovirus retinitis is common. Okay, yes, very good. Tuberculosis is the most common opportunistic infection associated with HIV positive individuals in India. याद रखना. Along with that, a question from microbiome and from medicine can be asked that which is the most common cause of diarrhea in HIV positive individuals. Can anybody tell me? A question in NEET PG was asked this time. Also in INS CET this question was asked. Which is the most common cause of diarrhea in cases of HIV positive individuals? And also the most common cause of meningitis, tell me. And also the most common cause of meningitis in immunocompromised or HIV positive individuals. ये दोनों के आंसर बता देना. Okay, here I am only talking about HIV. Most common cause of HIV, meningitis and diarrhea in HIV positive individuals. Tell the answer, guys. So please remember, guys, the answer to this question would be anybody the answer जल्दी. इतना टाइम कैसे लग रहा है? Anybody? Yes, very good, Komal. The answer to the most common cause of meningitis in HIV positive individuals, sorry, then the answer would be Cryptococcus neoformans. तो आंसर क्या रहेगा? Cryptococcus neoformans. So please remember, cryptococcal meningitis is the most common meningitis seen in cases of HIV positive individuals. No, not pneumococcal. Pneumococcal is the most common type of meningitis overall, but not in cases of HIV positive individuals. Not in cases of HIV positive individuals. The most common cause of meningitis in HIV positive individuals is a Cryptococcus neoformans organism. Please remember, Cryptococcus neoformans, which is an encapsulated fungus, जो इसका तुमने देखा होगा background staining, dark background staining, and India ink stain is used. Which stain? India ink stain. August का question. India ink stain is used usually. Right? Please remember. Now anybody, which is the most common cause of diarrhea in HIV positive individuals? So please remember, the answer would be Cryptosporidium parvum. Then the answer should be Cryptosporidium parvum. याद रख लेना. oocyst होते हैं 2 to 6 micron size के. So please remember, the most common cause of diarrhea in HIV positive individuals, the answer would be Cryptosporidium parvum. Most common cause of meningitis in HIV positive individuals, then the answer would be Cryptococcus neoformans. I hope this is clear to you. No mistakes would be done because both of these questions have been asked in both INS CET and NEET examinations. Okay. Moving further to question number 27. A 35-year-old man presented to the OPD with complaints of intermittent fever for 5 days, productive cough with shortness of breath. On physical examination, E is heard as A. Tubular bronchial breathing is heard over the right mammary area. Chest X-ray is given below. This is your chest X-ray. What is the probable diagnosis? So they are asking about your probable diagnosis. So the answer to this question is very good, Nirali. It is your option B, that is right middle lobe consolidation. So let's see. Chest X-ray पे क्या दिख रहा है? Which lobe is affected? So this is clear. This is clear. Here we can see some opacity. So please remember, which is this lobe? This is your right middle lobe. So please remember, there is a right middle lobe consolidation. Consolidation मतलब क्या? Consolidation is usually seen due to fluid accumulation, and fluid accumulation is seen in which lung infection? It is seen in the most common lung infection known as pneumonia. pneumonia. So let's see, are our symptoms persistent with our diagnosis? So a 35-year-old man presented to the OPD with complaints of intermittent fever for 5 days. Yes. Productive cough is there. Yes, in pneumonia usually we find wet or productive cough. Along with that, there is shortness of breath. Dyspnea can be seen. On physical examination, E is heard as A. This phenomena is known as egophony. So egophony is usually seen. Along with that, there is tubular bronchial breathing sounds. Okay, so along with that, they can also at times tell you that crepitations or crackles are heard. Okay, crepitations or crackles or rails can be heard in pneumonia, right? Along with that, chest X-ray shows you a middle lobe consolidation. So please remember, this is a case of pneumonia. Okay, please remember, Moria, it is middle lobe consolidation. So here you can see the middle lobar consolidation more commonly than the lower lobe. Okay, please remember this. So right lung is divided into 3 lobes, middle, superior, middle and inferior lobes, whereas the left lung is only divided into the superior and inferior lobes. Okay, then moving further to important features about pneumonia, jaldi padhenge hum. Okay, so please remember, pneumonia, most common cause for community acquired pneumonia. As we all know, community acquired pneumonia is the most common type of pneumonia, right? So which is the most common cause of pneumonia? Jiske naam mein pneumonia aata hai already. Okay, so that is your Streptococcus pneumoniae, also known as pneumococcus. So please remember, Streptococcus pneumoniae or pneumococcus is the most common cause of community acquired pneumonia or CAP. Okay, and what is the drug of choice for this? So please remember, the drug of choice for CAP would be azithromycin. Drug of choice for pneumococcal pneumonia would be azithromycin, or in some conditions we can also prefer doxycycline. Next, most common cause of nosocomial pneumonia. What do we mean by nosocomial? Nosocomial is an infection which is acquired from the hospital itself. So nosocomial or hospital acquired pneumonia. So the most common cause of hospital acquired or nosocomial pneumonia would be your Staphylococcus aureus. Staph aureus or Staphylococcus aureus is the most common cause of nosocomial or hospital acquired pneumonia. Okay, and usually this nosocomial pneumonia would be seen within 48 hours of admission. So within 48 hours of hospital admission, the patient will start experiencing symptoms like cough, shortness of breath. Okay, this is usually seen in cases of nosocomial or hospital acquired pneumonia. Next, most common cause of ventilator associated pneumonia. This question have been asked twice. So the most common cause of VAP or ventilator associated pneumonia. VAP की most common cause क्या है? Pseudomonas followed by Acinetobacter. So please remember, most common cause of ventilator associated pneumonia is Pseudomonas followed by Acinetobacter. And the drug of choice for the VAP would be piperacillin, because Pseudomonas or Acinetobacter would need a broad spectrum antibiotic like piperacillin. Therefore, piperacillin is usually given. Can anybody tell me piperacillin is given along with which combination? कौन सा कॉम्बिनेशन देते हैं इसके साथ? पाइपेरासिलिन प्लस क्या देते हैं यूजुअली? Therefore it is known as piptaz. So piperacillin is the drug of choice for ventilator associated pneumonia. Then the most common cause of pneumonia in HIV positive individuals, the question that we have already seen, that is your most common cause of pneumonia in HIV positive individuals is your pneumococcus. But if they say that the CD4 count is less than 200, then your answer would be pneumocystis jirovecii or carni pneumonia. Okay, याद रखना. So it is your pneumocystis carni or jirovecii pneumonia. Most of the times the answer would be pneumocystis carni or jirovecii pneumonia, because in HIV positive individuals the CD4 count is usually low, and the most common opportunistic infection is also pneumocystis jirovecii or carni pneumonia, which presents with non-productive cough. Right, it is a atypical thing. In pneumocystis jirovecii or carni pneumonia, there is a non-productive cough, unlike pneumococcal pneumonia जिसमें productive cough होता है. Along with that, in pneumocystis carni pneumonia there would be perihilar involvement, whereas in pneumococcal pneumonia there would be one lobe completely affected. Right, याद रखना. Yes, very good. It is known as tazobactam, which is given in along with piperacillin. Very good. The drug of choice for pneumocystis jirovecii pneumonia क्या था? Cotrimoxazole. The drug of choice for pneumocystis jirovecii or carni pneumonia would be cotrimoxazole. The most common opportunistic infection in AIDS is tuberculosis, when the CD4 count is below 500 cells per cubic millimeter. This is, I am talking about India. याद रख लेना. ठीक है. When the CD4 count is below 200, there would be toxoplasmosis, and when the CD4 count goes beyond less than 100, then it would lead to neurotoxoplasmosis. CD4 count less than 50, it would lead to CMV retinitis, or it can also lead to MAC infection, that is Mycobacterium avium complex infections. Then if there is an alcoholic presenting to you with all the pneumonia symptoms, so usually you will think of which organism? So please remember, an alcoholic presenting to you with all the pneumonia symptoms along with a characteristic red currant jelly sputum. क्या दिखेगा? Red currant jelly sputum. Then the condition would be, okay, the most common cause of pneumonia would be Klebsiella. So please remember, an alcoholic suffering from pneumonia along with red currant jelly sputum, the most common cause would be Klebsiella. The most common cause would be Klebsiella, also known as Friedlander's bacilli. The chest X-ray of Klebsiella pneumoniae would usually show us a bulging fissure site. A widened fissure would be seen. Okay, so please remember, a bulging fissure sign is usually seen in cases of Klebsiella pneumonia. Please remember this. Next is your CURB 65 score. Okay, next is your CURB 65 score, in which C goes for confusion, B goes for blood urea nitrogen, okay, R goes for respiratory rate, that is tachypnea, when respiratory rate is more than 30 per minute. B goes for blood pressure, that is hypotension less than 90 by 60 millimeters of mercury, and 65 means more than 65 years of age group, which is commonly involved. Okay, and more than 2 score out of this is suggestive of ICU treatment. ठीक है, याद रखना. C confusion, B blood urea nitrogen which is elevated, R for tachypnea more than 30, B for hypotension less than 90 by 60, and 65 means more than 65 years of age group, and more than 2 score is suggestive of ICU treatment. Okay, then there are atypical or atypical pneumonia. Pneumococcal pneumonia is a typical pneumonia, whereas atypical or walking pneumonia, in which the patient is completely fine. The patient is either asymptomatic or mildly symptomatic. So that the most common cause would be Mycoplasma pneumoniae, in which there would be cold Landsteiner antibodies which would be found. Cold Donath-Landsteiner antibodies. Okay, that can land up the patient into PCH, paroxysmal cold hemoglobinuria. Okay, whereas one of the causes of atypical or walking pneumonia is also Legionella, which is associated with AC exposure, humidified air exposure, and that can lead to Legionnaire's disease, which is a type of atypical pneumonia, which will also present with diarrhea along with pneumonia. Okay, and next is your Pontiac fever, which is a mild upper respiratory tract infection, again seen with Legionella. And last is your bird handler's pneumonia, which is also known as psittacosis, which is due to Chlamydia psittaci, the drug of choice for which is doxycycline. I hope this is clear to you. Pneumonia is very important, therefore I have been explaining to you all these features. Otherwise we would have moved further. Next, question number 28. A 30-year-old female was admitted to the casualty with hysteria and anxiety. The physician extracted blood for arterial blood gas, that is ABG interpretation. The ABG report revealed a pH of 7.55, bicarbonates of 24 milliequivalent per liter, and a PCO2 of 27 millimeter of mercury. What is the interpretation of this report? So this is very much important, guys, from clinic's point of view also, and from your examination point of view, that ABG analysis is a very important topic that you need to know. Can anybody tell me what is this condition? In the meanwhile, I'll tell you that first of all, ABG जब हम करते हैं, arterial blood gas analysis, guys, in that we need to either find out whether the person is suffering from alkalosis or acidosis. So for that purpose, we first of all check which parameter? We first of all check pH. Okay, pH is the most important parameter. So pH, normal pH of the body is 7.35 to 7.45. So neutral pH usually अगर pH scale पे दिखेंगे that is 7, but the neutral body pH would be 7.35 to 7.45. So anything less than 7.35 would be considered as acidosis, whereas anything more than 7.45 would be considered as alkalosis. Right? Anything less than 7.35 acidosis, anything more than 7.45 alkalosis. Okay, सबसे पहले क्या देखना है हमें? pH देखना है. Then we'll see whether this pH is due to whether this acidosis or alkalosis is due to a metabolic component or a respiratory component. So for metabolic component, we check the levels of bicarbonates. For metabolic component, we check the levels of bicarbonates, whereas for respiratory component, we check the level of PCO2, that is your partial pressure of carbon dioxide. PCO2 levels check करे जाते हैं. What is the normal bicarbonate level? Now the book differs. Okay, बहुत सारे book differ करते हैं, but usually the value which we prefer in our clinics, okay, and the textbook also suggests, that is 22 to 28 milliequivalents per liter. Okay, याद रखना, most of them can give you that till 32 milliequivalents per liter bicarbonate values are normal, but please remember the preferred value would be 22 to 28 milliequivalents per liter according to Harrison's, and as we all know Harrison's के आगे कुछ नहीं होता है, so 22 to 28 milliequivalents per liter usually is the preferred value of bicarbonates of normal range. Then PCO2 value normally कितना होता है, 40 millimeters of mercury. Normal PCO2 value is 40 millimeters of mercury. So basic चीज़ क्या याद रखनी है, याद रखना metabolic component is given by bicarbonate, respiratory component is seen by PCO2. यहाँ पे क्या याद रखेंगे, bicarbonates are alkaline in nature, right? Bicarbonates are alkaline in nature. So therefore whenever bicarbonates are less than the given range, there would be metabolic acidosis. Whenever the bicarbonate levels are less than the given range, there would be metabolic acidosis. And whenever these bicarbonate levels are more than the given range, as alkaline substance is more, therefore there would be metabolic alkalosis. There would be metabolic alkalosis. Whenever CO2 is acidic, right? CO2 acidic होता है. So whenever PCO2 levels would rise, that would give rise to respiratory acidosis. That would give rise to respiratory acidosis. And whenever PCO2 levels would fall, as acidic component is decreasing, that would give rise to respiratory alkalosis. So in this condition, what can be seen? A pH of 7.55, that is more than 7.45. Therefore, this condition is alkalosis. So is conclusion तक तो आ गए that it is a alkalosis. So now whether it is metabolic or respiratory, ये देखते हैं. Bicarbonate level is 24 milliequivalent per liter, which is normal, right? It is within the normal range. PCO2 is 27 millimeters of mercury. So it is normally 40. So it is less than that. So if acidic component like PCO2 is decreasing, that is the patient is in alkalosis. So this condition is option C, respiratory alkalosis. I hope this is very much clear to you guys. और इसी को चेक करने के लिए आई एम गिविंग यू वन मोर एग्जाम्पल, जल्दी से इसका आंसर बता देना. हियर द पीएच ऑफ द पेशेंट इज 7.2. ओके, द PCO2 इज 45 mm of Hg. Bicarbonate level is usually 12 milliequivalents per liter. Can anybody tell me what is the diagnosis? जल्दी से इसका diagnosis बता दो, फिर we'll move on to the next question. pH 7.2, PCO2 45 millimeters of mercury, and bicarbonate level of 12 milliequivalent per liter. Can anybody tell me what is the diagnosis, guys, in this condition? Any one of you? जल्दी से बता दो, easy. pH क्या दिखा रहा है? Acidosis, alkalosis? It is metabolic acidosis. Very good, Nirali. Along with that, there is some important component also, right? So याद रखना, pH is showing us acidosis, right? Because the pH is less than 7.35, therefore there is acidosis. ये पता लग गया. Next, PCO2 क्या दिखा रहा है? 45. It is increased. Okay, so please remember. 45 है. So acidic component इधर भी है, respiratory में भी है. Okay, respiratory में भी acidic component है. And bicarbonates is also showing what? Bicarbonates is also showing decreased value. That is also showing acidosis. So please remember, this condition is both metabolic as well as respiratory acidosis. This condition is both metabolic as well as respiratory acidosis. It is not compensatory. Compensatory is not this one. Please remember, guys, pH is 7.2 and both of these features are going in that favor. Matlab 45 PCO2 which is increased, bicarbonates 12 which is decreased. So all of them are pointing towards diagnosis of acidosis.